Okay, so thank you very much, everyone, for coming. We've got three hopefully fantastic speakers today. I'm sure they will be. And it's a 12 minutes per presentation. And do you want me to let you know at sort of a few minutes to go, or roughly? Okay, and then a few more minutes, 5 minutes or so for discussion. So thank you very much.
Hi, everybody. My name is Reese Green. I'm a research assistant in the System Science Unit. I work with Johnny Stokes mainly, and I'm going to be talking today about the scoping review that I'm working on, and it is focused on understanding the social determinants of health as a complex system. So just to give a little bit of an overview.
Yeah, just minimize it.
Okay. Just to give a little overview, kind of why we're interested in this topic. There's a lot of evidence that health and inequalities are worsening. The bottom figure here is just showing that life expectancies and kind of healthy life have been decreasing over the years. And then the top figure is showing that this decrease is falling along a social gradient where the most deprived folks are kind of experiencing the worst health outcomes. And people often cite political inaction as the kind of core cause of these health inequalities. Like that person.
There's someone online admitting people, so.
Oh, cool. Okay, perfect. Yeah, people often cite political inaction as the core cause of these health inequalities. If only we could kind of spur policymakers into doing things, then we could fix this. But unfortunately, if we look at sorry, I'm seeing this slide there for some reason. But I had an example of if we look at governments and contexts where there is political inaction, such as in Norway, where there's a big effort to improve health inequality specifically, we actually don't see a decrease in health inequalities, despite quite specific goals and money thrown at the problem. There are still pretty much no improvements. So that raises a lot of questions about what exactly are the underlying mechanisms that are resulting in these health inequalities that we see that are quite resilient to different policies. So health inequalities have been described as a wicked problem. Like I said, they are remarkably resistant to improvement. There's a lot of questions of kind of what scale should we be looking at health inequalities, because health happens to an individual, but we measure health inequalities at an aggregate level. We measure them across populations, and we don't know exactly at what time point kind of different factors might be most important to target in terms of policy. So this visual here is just looking kind of at income as a specific determinant and how it operates across different levels of aggregation. So obviously individuals have income, and that might affect their health behaviors and might affect whether or not they have private health care, their general purchasing power. On a community scale, the community's income is going to affect resources like education, transport, local services, and it will be affected by the local job market. And then at a wider level, things like gross domestic GDP, trade, and social safety nets and benefits are all also going to affect income. And these are not kind of isolated to these levels. They impact each other, and they impact lots of other determinants as well. So this can get really messy really quickly, and how exactly to intervene becomes quite unclear. So there's a wealth of research that looks at specific correlations between social determinants and health outcomes. This question is quite clear that these relationships exist, but we still are not quite sure how to turn this research into policies that help people. These are some frameworks that have attempted to describe some of the complex interactions between different determinants, different levels. The one on the bottom right of the screen is the WHO's Commission on Social Determinants of Health. It's quite popular. It breaks things down into structural determinants and intermediary determinants. And we'll have some feedback loops going on. But in general, there's a need for more clarity on how these determinants operate as a complex system. And that may offer insights into different leverage points and really specific ways to take action. And so a system science lens might help us identify kind of who who needs to help benefit in what ways, where we can help them, at what point in time, as well as how. And the system science kind of suite of methods can allow us to test through different simulations and modeling techniques how an intervention might affect people in a population and how they interact with each other, and how that gives rise to the population level health inequalities that we see. And this can be done in a really localized and optimized way, so that you get specific interventions for populations, which is very exciting to see. And this figure at the bottom here just is kind of showing characteristics of a complex system. These systems are really defined by the fact that there's elements within them that interact and give rise to emergent behavior. So the general, I guess, gist of it is that the whole is more than the sum of its parts. So the aims of this review that we're writing is to look at the existing literature and look at how multiple social determinants of health and health outcomes have been described through system science concepts, through things like emergence, interrelations, feedback loops, and try to see what we know about social determinants as a complex system, and then also if we can identify any policy implications or evidence gaps that remain that we need to target in the future. So currently, just to provide a little overview of the search strategy, we're really interested in kind of these big scoping and general topics, so general populations, not looking at subpopulations. We're interested in determinants across a variety of levels, so not just within individuals, but from individual to regional, from regional to national. And of course, we're interested in being focused on papers that look at social determinants of health through a complex systems lens. So some of those features that I mentioned before. And for feasibility, we're limiting this to English. So currently, we just finished with the abstract and title screenings. There's 173 articles that we have in the full text review. And the next step is going to be narrowing that down to a final sample, extracting data, generating figures, and writing up where we find. But some very preliminary findings. We have noticed that a lot of articles are looking at biological pathways. They're looking at how social determinants get under the skin in terms of epigenetic alterations and biological embedding, and that has kind of consequences for the life course in terms of how the brain develops, and how early life experiences can propagate over time and over generations. There are a handful of papers that look at different specific modeling applications and interventions, these microsimulations and agent-based models that I mentioned. And then there's a lot of studies that take kind of a slightly more conceptual approach of looking at almost like philosophical explorations of this, of like, oh, what does it mean to have agency in your life, and how does that impact your health? But then there's also some like studies that look at dynamics between different levels of aggregation, intersecting identities, and investigating these impacts over the life course. But that's just kind of, we're at a very early stage, but this is kind of what we're finding is being pulled out. So there's still quite a bit of room for research in this area. It's very much at its beginning stages. Some of my concluding thoughts are that we've identified that this is a systemic problem. Health inequity operates at many different levels. So exploring this through system solutions might offer different insights. There are missing key pieces of information that could help guide policy, like what point in life is the most impactful to operate on. How do community interventions versus individual versus economic interventions differ in their efficacy? How does place kind of impact your resource access? And all of these questions will be complemented by kind of the historical existing approaches. There is a lot of research that has been done in this area, like I said, and there's probably not going to be some sort of silver bullet or single cure. Ideally, there'll be a synergy between the tools of system science and what already has existed. And finally, back to kind of the lack of political action debate. systems perspectives may be really motivating for change, for policy change, because we might be able to say, oh, we ran this model in this area, and this particular leverage point looks to be the most optimal for improving something. And again, like no model is perfect, but some models will be useful to guide policy. So we might end up with new insights and new recommendations through these methods, but we'll kind of see what we're able to pull out. So, thank you. This is the study protocol if anybody is interested in kind of reading more specifically up on what we're doing.
Anyone got any questions?
I really enjoyed talking to a person. So it's like not my area of research at all, so apologies if it's really naive. But I would think that things such as history and economics and politics play a huge role here. So if you were, comparing Scotland with Germany, there's obviously going to be very different drivers of inequality in Germany. To what extent will you be able to model the long-term historical, economic, political drivers? And how would you even begin to intervene upon them?
Yeah.
Sorry to interrupt, Reese. Can you just, or can we just repeat the question, or did anyone else hear that online, just so people online can hear? You hear that, Johnny?
Yeah, we got the gist of it. I think historical factors playing a big role.
Yeah, that's a great question. And so that is for sure, like when we were looking at these articles to add to this review, there's a lot that look at, like in Germany, for example, like really specific economical impacts. And I don't know exactly, like we're not looking here to describe like those kind of specific contexts, more to see if there are general drivers that could be applied to specific situations. So if you had an agent-based model, for instance, you could incorporate rules that are specific to that context. But we're kind of interested in, well, within that context, are there any general drivers that do exist? But I know that, yeah, history has a huge impact on these things, but we're kind of interested in whether there are overarching themes.
Anyone else? Anyone online? Yeah, Alistair.
Thank you for your talk. I found that really interesting. I think it's like obviously the social determinants are sort of like everything in the world.
Yeah.
Like so it's like in the field of where like it's like food systems, or like they've took an in-depth view of a systems lens, like how the food environment or maybe physical activity or the built environment. Are you sort of including those sort of specific things that have looked at those specific social determinants, as well as trying to create sort of more holistic thing as well, or how are you incorporating those like more focused systems things that are already sort of developed?
That is a great question. It's one of the things that we've kind of chatted about quite a bit, of which, I mean, so the way that social determinants have been described, it's like they're pretty much everything. And so thinking about which one's the most important is important to narrow down the question. We included studies, like for instance, there were a lot around nutrition. We would exclude it if the main topic was just nutrition, but if it was looking at, oh, how does this social determinant interact with income, interact with education, interact with early childhood experiences, then we were including it to get a sense of kind of, rather than this isolated chain, kind of how is that specific determinant fitting in with the other determinants, if that makes sense.
It's a nice presentation. Thank you. I'm just wondering how you will draw the boundary of your model in thinking about this, because of the huge elements of the social determinants, as well as is there any specific way you are thinking to validate the model? Because at the end you will draw a causal loop diagrams or similar things, or later you may need to validate the model with a historical pattern.
We're kind of looking right now just to describe how social determinants have been investigated in the research. So rather, like the output won't be like a model, but it will be like, I'm really interested in looking at, okay, how has like nutrition, how has income been described at an individual level, at a community level, at a population level, and then looking at how they've been described in terms of interacting with each other. So yeah, we won't be like training a model in terms of the output. It's more of looking at, well, what has been said and what is missing from this conversation.
Well, that's a good question.
Yes.
You gave the example of Norway at the beginning, where it was being upheld as maybe if it could work there, or if it didn't work there, then it couldn't work anywhere. But I was wondering if you could say more about that example, what was tried and why it might not have worked to reduce inequalities.
Yeah, well, they looked at, so there was a commission that went in and identified, I mean, very similar to, if anybody's familiar with the Marmot report here, went in and kind of identified key goals for policy, and they took the approach of getting exactly what the name of it was, but I think it was like a leveling up, where they specifically looked at improving things for the worst off groups. So one of the targets was, I think, improving educational inequalities. And when they looked 14 years, it was 14 years later, they just didn't see any improvement in the inequalities. So while Norway is an example of somewhere where overall there's less inequality, it's the health inequalities that they haven't managed to improve.
Thank you. Thank you very much.
Thank you.
Thank you. Give you like a 2-minute warning.
Yeah.
Thank you so much.
So, good morning, everyone. I'm Francesco Manca. I work here at DETA. And this morning I'm presenting a study on the this inequality in the distribution of prescription for alcohol dependence in Scotland, which is comprising also a comparative effectiveness between the two most prescribed drugs for alcohol dependence, which are acamprosate and disulfiram. The study basically produced also a bit less than a year ago a paper, and it was funded by Alcohol Change UK. I wanted to try to start this presentation showing basically in comparing the distribution of alcohol dependence prescription and the distribution of prescription for other mental conditions such as anxiety. If we look at the left-hand side here, we can see that the distribution of alcohol dependence prescription is highly skewed towards the most deprived groups, most deprived quintiles, having almost 5 times more prescription than the least deprived. The distribution is way less skewed for antidepressant, and we can see that the most deprived groups have only 1.8 more prescription than the least deprived. If we start to look at the actual socioeconomic notes to the alcohol-related harm in society, and then we use the alcohol-specific deaths as a proxy of alcohol-related harm, we can see that these figures almost reflect what we saw earlier, that the most deprived groups have almost 4.5 times more alcohol-specific deaths compared to the least deprived. While if we shift the focus on the DALI, so the burden of alcohol in society described by DALI, we can see that the burden is quite higher, and that the most deprived groups has almost 7.5 times more DALI than the least deprived. Here we increase on quintiles, even if there is a big difference. So from these figures, we can see that certain subpopulation, and then especially we see male, but also those living in more deprived areas, receive more treatment. However, this subpopulation are also those experiencing more harm related to alcohol. So our question was allowing and then focusing on the higher risk population. Do individuals' characteristic and subpopulation actually experience different access to care regarding alcohol dependence? We then developed 3 different research questions. The first one is there any difference in the odds of receiving any prescription for alcohol dependence across age, sex, and socioeconomic deprivation prior and after first hospitalization, so an acute event for the alcohol use disorder? Then what is the most effective medication for alcohol dependence? And here we compare the 2 most frequent medications that are acamprosate and disulfiram. And the last one is there any difference in the odds of receiving the most effective medication across age, sex, and socioeconomic deprivation? So looking at the descriptive trends, and then this describes basically rate of individuals receiving prescription in the 60 days after the first acute event, we can see that in relative terms, individuals in least deprived socioeconomic groups receive more prescription compared to the most deprived. Similar trends, female receive more prescription, as well as central age categories. Everything in relative terms. So we started to ask this question also inferentially. We built a cohort. The first cohort was identify all individuals that had a first hospitalization in the last 10 years for alcohol use disorder. And then we checked whether specific characteristics were associated with the odds of receiving treatment, pharmacological treatment before and after the event. And we used 60 days as a windows. What we saw is basically that sex, age, socioeconomic deprivation, and a history of mental health comorbidities were all associated, significantly associated with the odds of receiving medications. So especially being male was associated with a 21% lower odds of receiving prescription. Similar for age, you were more likely to receive prescription in the middle age category groups. Then least deprived, if you were living in the least deprived area, you had 63% higher odds of receiving medication, as well as for mental comorbidities. We have a similar pattern if we look after the first acute event, except for mental health comorbidities. However, the extent is slightly lower, and this makes sense because basically after an acute event, everyone is a bit more prone and likely to seek care. However, it's quite interesting to see that when we remove the 60 days constraint and window, and then we check all the time after having an hospitalization, basically the association of socioeconomic deprivation kind of disappeared. This basically means that it's quite relevant and important just in the periods after an acute event. So there are more differences across different socioeconomic deprivation seeking care. In this case, after an acute event. We then did the comparative effectiveness. We built a different cohort. The cohort here was identifying all individuals with a first prescription for alcohol dependence ever without any previous hospitalization. And we assessed the time to first hospitalization. And then we compared acamprosate and disulfiram, and we saw that across different methods, being prescribed disulfiram was associated with a 40 to 27% reduction in the hazard of having a first hospitalization for alcohol use disorder. We did the first analysis on across characteristics, trying to understand whether certain characteristics could give you more, were associated with the prescription of the most effective drugs. We saw that all the characteristics that were previously relevant were not relevant anymore, except for socioeconomic deprivation. And actually, in the least deprived area was associated with an increase in the 78% of being prescribed disulfiram, which was the most effective drug. So basically, those living in most deprived areas had less odds of receiving the most effective prescription. So in conclusion, in absolute terms, we saw that more hospitalization and prescription happen in the more deprived area. However, these are also the areas experiencing the higher burden. So, and then in relative terms, also they have less odds of receiving prescriptions, and they have less odds of receiving the most effective drugs. This, of course, has a quite big implication for the distribution of the social burden of alcohol in society. And it's quite interesting to see actually how basically there was this kind of inequality was more present in the time just after the first acute event. Of course, we believe that there is a need of understanding the reason why of this. The reason why there is kind of inequality in receiving care. There is a more need to understand in the reason why basically why certain populations are offered less effective medication, And then after understanding this, there is a overall need of design more complementary strategy in order to try to even the burden of alcohol in society. Examples can be trying to boost a bit more the assertive outreach, especially in the moments just after acute events such as hospitalizations. Of course, there is a short reminder that the superiority of disulfiram, like in our comparative effectiveness, is not only due to pharmacologic characteristics of the drugs. We were looking at the big data sets, and then a lot of other components are present in these, such as the severity of dependence, patient motivation, and close monitoring, which are actually can be potentially associated with the level of socioeconomic deprivation as well. On the limitation, of course, we had only data set regarding prescription and hospitalization. The main outcome were hospitalizations. However, there can be more meaningful outcome, especially regarding addiction, and then in this case, alcohol dependence. So, for example, the number of days of abstinence and the quantity of alcohol consumed. Another limitation that we only focus on pharmacological treatment. However, there are other forms of treatment that can be also quite meaningful and sometimes even more meaningful, but we didn't have the availability of them. And that's me.
Any questions?
Thanks, Manca. That was very interesting. Kind of, I was thinking about that point just before you made it about the superiority of the sulfiram to compensate, being maybe because of confounding rather than because of pharmacological superiority. Is there a biological plausibility that there is superiority between one and the other? And have there been any comparative trials where, in the ideal scenario, where you're controlling for one?
So basically, they act way differently. Acamprosate acts trying to restoring the neurological pathway, basically damaged by alcohol.
Yeah.
And then the aim is trying to keep you the abstinent, while disulfiram is more a deterrent effect. So basically it's based on giving you nasty feelings like nausea, vomit, and other things when you inject alcohol. So motivation is one of the driving factors of choosing between the two. Trying to understand and try to neutralize kind of confounders, we use different kind of methods. The last one is like physician prescribing preferences. So basically we use as an instrumental variable in order to get trying to minimize kind of potential confounders. However, it's fairly to say that at the end, this overall socioeconomic deprivation can be quite correlated with motivation itself, and then especially with the availability of supervision, which is one of the things suggested to adopt disulfiram. So the question will be why in certain areas, so how can we tackle basically the less availability of supervision? Should we try to address more promptly certain subpopulation that can be more vulnerable? And this is basically the question.
Yeah, thanks. I have pretty much the same question as Heather, but in a slightly different way. So it seems to me there's probably, yes, there's inequality, but there's also likely confounding by indication. You know, with and you know, how are you going to fix this without solving the whole social problem around alcohol industry that would allow greater prescription of an effective drug if it needs more intensive support, risk of adverse events and things like that. I think from the prescriber perspective, if you told prescribers to change your prescribing practice, they would push back and say this is not going to be a safe thing to do.
No, the very interesting thing we show what we saw when we did this kind of instrument is actually that there was a lot of reference. So
preference for the more effective drug.
The instrument basically is you try to track the last 10 prescription of every physicians, and then you use basically the rate of which choice of one against the other is the prevalent whatever physician. This basically try to underline if there is an inner preference of one physician of one drug instead of one other.
It's a preference if you're doing that. It's, you know, perhaps they just live in an area where there's a lot of people who are not able to have the support.
Everything, like especially with the propensity score and everything else, was adjusted by also the socioeconomic area. So like it was quite, there was a point idea of trying to control for those things. So basically we adjusted by indication for those variables.
So yeah, so anyway, so the second part of my question is then, what is the intervention to solve this issue?
So I think try to in the moment where an individual is more vulnerable, like just in the moment just after the hospitalization, where individuals are more prone to relapses, there is not an actual instant connection and link with or specific services or basically having follow-ups. And then we found this through also qualitative assessments that there were individuals that felt kind of abandoned. So the idea is trying to link more and then building stronger links between after hospitalization or after acute event with social services or actually just with a GP or something else, without leaving everything up to the individual seeking care. Since in certain subpopulations also are there trying to do. This is basically.
Anyone else? Anyone online? The question about the assertive outreach. So I work with the GP in the northwest of Glasgow, and there's an assertive outreach about alcohol. But my understanding is that there have been some changes to the service and there wasn't an assertive outreach before. Is there any granularity in the data that you could look to see where and when?
This data is likely oldish, not very, like just before the pandemic, but then we did some focus group after with the patients. I think what patient experienced, it was more, they kind of felt there was a lot of difference across GP practices, and then in the how also they were understood by the GP and then addressed to actually services. One of the main things they underlined was the lack of, like after hospitalizations, for example, of being linked with any kind of service. And we believe that that one was one of the actual driver of it. There is, I know there is the alcohol and drugs partnerships. Okay. Yeah, that actually try to do assertive outreach, but is a bit more focused on illicit drugs.
Okay.
So yeah.
Thank you very much. It's 3 fantastic people. There are still speaker slots available for future seminars like this. So if you want to get some feedback or tricky questions from a good audience, then please let me know. Thank you. Thanks, Johnny.
Thanks, Amos. Cheers.
Yeah, I wanted to thank you, but I wanted to ask about the outreach. So is there availability to look at where assertive outreach is, where it's not, see if there's any difference?
More on so in certain areas,
yeah,
like
Talk to me. Oh, okay. Well, I'll wait outside and speak to you outside.
Okay.
And then,
Oh, sorry, I wanted to thank you so much. That was really, really interesting. Yeah, and I hope you're okay with this point here that one of our cross.
Yeah, because I thought it's a small group, and I think it's okay. I think it was
because it will be recorded. So what I can do,
but it should have been told me before that.
My apologies. I think, what I can do is I can get that bit taken out of the video.
Because what happened is that's the reason I shared, because I thought I was told that it's a very
small
informal
group.
Yeah,
it is a very informal group. It won't be shared yet, but it does get shared on the YouTube channel, University YouTube. So I will make sure that it is not shared from that point of view. So thank you. Okay. Yeah, sorry.
No. So basically, I think I'm
Yeah.
I'm leaving a bit behind the auto thing, and I'm going a bit more on the easy drugs. But